hang on 2 seconds. All right. All right. Good afternoon, everyone. And thank you so much for joining us today. I'm very proud to present two of my ex fellows to look after this meeting. My God, the children have grown up. First of all, our speaker is Dr. Parvesh Garg, now from Alabama, and he's going to be speaking to us on what happens to the kidneys and brains in preterm infants with NEC. But looking after Parvesh is Dr. Anki Reichmacher. I always say that wrong because she's our kidney expert, and she'll be leading the discussion and looking after us with Parvesh's talk. So without further ado, I'll hand it over to Parvesh and Anki. Yes, thank you so much again, both of you, and over to you.
Uh, First of all, good afternoon, Australia. It's an honor. First of all, I'm grateful to Dr. Julie for giving me this opportunity to share our work in this area of surgical neck, where we studied about surgical neck associated AKI and the brain injury. I'm an associate professor of neonatology at Wake Forest School of Medicine. I have no conflict of interest. In this study, I would be talking about neck pathophysiology. I have divided the talk into three parts. First is neck pathophysiology and common clinical questions. So we will talk about outcomes based on age of neck onset, sex, and the type of intervention they receive, like Penrose drain versus laparotomy. What is the impact of surgical timing, whether you operate early or later, how it impacts the outcomes in terms of AKI as well as in terms of brain injury. We'll also tease out a little bit about the difference between NEC and SIP, because right now we are treating them as a separate entities, but it looks like they may lie on the same spectrum of the disease. And we will also talk about NEC-associated AKI and the brain injury, its risk factors and its outcomes, how it affects the NEC outcomes, and what all factors we can modify to improve the outcomes of these two severe NEC-associated morbidities. So if you look at that, necrotizing enterocolitis is a systemic inflammatory disease. It happens in 5 to 10% of cases of premature infants who are less than 1.5 kilo. And it's the leading cause of morbidity and death in preterm babies, almost 40% mortality, up to 60% in some units. And it is an expensive disease. It causes a lot of dollars to take care of these babies in the NICU. Because of the TPN dependency, and sometimes they need multiple surgeries and follow-up later on also. So this is a typical presentation of a neck baby. You see a baby with a distended abdomen, make NPO, repoable to suction. And X-ray is still the very common modality to diagnose neck. You see a lot of portal venous gas, as you can see, or pneumatosis intestinalis. But there is an evolving role of ultrasound in surgical neck, still because of implementation barriers and standardization of providers, as well as a lot of system issues. It has still not become the first line diagnostic modality in every center of the world. Right now, it's still lagging behind. Still, X-ray is the gold standard, and the clinical picture is the gold standard to diagnose surgical neck. In this cartoon, I have tried to summarize how the neck happens. There are many multiple pathophysiological factors comes together, leads to intestinal necrosis. If you look at this, there is an immature intestinal barrier. The tight junction proteins between the intestinal epithelial cells are not mature. So all these bacteria can pass through in the systemic circulation. That's one thing. There is an altered microbiota. If you look at there's a dysbiosis. The routine colonization with the good bacteria does not happen in the light with the exposure of antibiotics. Dysbiosis, we'll talk about it in a little bit. And some genetics, like some proteins are traditionally gestational wise, they are pro-inflammatory until certain age, like up to 30 weeks, and they become anti-inflammatory afterwards, like especially the toll-like receptor. There has been a lot of understanding about role of toll-like receptors, especially to TLR4 and 9. And all these and prematurity, all this leads to exaggerated inflammatory response, and you get intestinal necrosis in babies with surgical neck. If you look at the histopathology, this is a histopathological diagnosis like BPD. If you look at the neck, it's a necrotizing enterocolitis. In 60s, 70s, when this diagnosis was put in the place, it had mainly 4 lesions. It has necrosis, You see a lot of necrosis, you see inflammation, you look hemorrhage, and the respiratory changes. If you look at the data for last 50 years, we basically see neck from the standpoint of clinical standpoint. But lot of but this disease is very different depending on the level of necrosis you see in the baby, level of inflammation or hemorrhage or respiratory changes. Because if you have a lot of respiratory changes, you will see strictures. But if there is a lot of hemorrhage, you will see a lot of hypotension, AKI, or brain injury because it's affecting the perfusion of the baby. And if there is a lot of inflammation, you may see a lot of lung issue, lung associated, neck associated lung injury. So this is very important to know in your histopathology report what kind of level of injury this baby had, whether it's a severe injury, mild injury, moderate injury. So this is a just slide to everybody knows about it. The management of surgical neck. If it is suspect neck, we do 48 hours of antibiotics, bowel rest. If it is advanced medical neck, 7 to 10 days of five. It's up to 5 to 10 days depending on the clinical course. Antibiotic, bowel decompression, and the monitoring of the labs. And in surgical neck, basically, if it is a perforation or baby surgically sick, either you do laparotomy at bedside or in the OR or you do the placement of Penrose drain. So these are the typical management strategies of surgical neck. So let's start what happens antenatally. The neck does not happen postnatally. It may happen postnatally. It happens postnatally, but the onset may even starting antenatally also. So we did a study. This is our own work where we looked at how the placental lesions affect affect necrotizing enterocolitis. So in this study, we looked at the placenta. We looked with in this study we took 237 patients, and with the control of 130 cases were control out of that. And we found that babies, and we looked at the placenta of all these babies, and we classified the placental lesions separately by the Amsterdam classification, which has 6 criteria. And we found that these are 6 criteria, as you can see here. And we found that babies who have a lot of like acute histological chorioamnionitis or chorio with fetal response, even the vascular lesions, and they were associated more with neck as compared to control. Secondly, these babies had mixed lesions. It's just not one kind of lesion leads to neck. It's a combination of lesions like your vascular lesions as well as the inflammatory lesions comes together and prime the gut in antenatal period, and when the baby is exposed to a lot of exposures after birth, like antibiotics or any PDA perfusion issues or formula feeding. So there's a double hit mechanism which leads to intestinal necrosis, which probably affects the genetics of the neck, as we will learn more down the line. If you look at this, so in this study, we found the conclusion of the study was infants with multiple placental lesions, including placental, inflammatory, and vascular lesions, were high risk of medical surgical neck in the post. So why it is important? Why I'm showing this? Because you have to include placental pathology in your day-to-day management. You have to see whether I'm dealing with a baby with PIH, vascular lesions, or I'm dealing with a baby with the inflammatory lesions, or combination of both. And you have to watch this baby very, very carefully for first 4 to 5 weeks of life until baby is more than 32 to 33 weeks of life. Because any postnatal hit can lead to surgical neck or medical neck. So other important issue is if baby has got a lot of these lesions, and there is a common practice to expose these babies with antibiotics postnatally. We feel that baby got exposed to infection, inflammation, so antibiotic courses are given. So in the same cohort, we looked at how the antibiotic exposure affects neck or surgical neck. So in this study, we divided the cohort in the babies who received antibiotics for more than 3 days versus babies who did not receive, who received antibiotic less than 3 days. And we found that so in this cohort, almost equal, the cohort were almost equal. 48% received antibiotic less than 3 days, 51% received antibiotic more than 3 days. And we found that on multivariate regression, the odds of getting medical neck was 2.6 versus and 3.3 was a surgical neck cases if their exposure to antibiotics more than 3 days. But the prolonged antibiotic duration did not affect the overall mortality. It did affect the outcome of neck in these babies. But if we just look at the neck cohort, we found that if you look at the neck cohort, babies who were exposed to more antibiotics more than 3 days, they were at high risk for mortality. So limiting the antibiotic duration is very important. There is no randomized trial in this area where they have studied the duration of antibiotics in surgical neck cases. If you look at that in all the cases in the adult world, in the pediatric world, the duration of antibiotics has come down even with appendicitis and all. So this is limiting the antibiotics. The cultures are negative, try to stop antibiotics early, use very judiciously. So regarding uh, in pathophysiology, there is a lot of understanding since last 20 years about microbiota, and we know that there is a dysbiosis in surgical neck. So in our this study was done at our center. What we did, we wanted to look at among dysbiosis, some babies survive and some babies die. So we wanted to see what kind of dysbiosis is good, where you can say you can survive, and uh, what kind of dysbiosis makes you at high risk for mortality. So what we did, we took the sections like FFP section. These are the frozen formalin fixed sections, paraffin embedded intestinal tissue, which comes after the surgery. And we did the 16S RNA sequencing of the microbiota profile with the human tissue in the survivors and non-survivors tissue. And we found that if you look at if you know that in these babies, this biasis involves your colonization with acidinobacteriota, is a phylum level, Firmicutes or proteobacteria. But we found that babies who survives, which is blue in color, as you can see, they have more proteobacteria like E. coli, Klebsiella. Probably we are able to better manage with antibiotics as compared or ratio of these protobacteria versus Firmicutes or ratio of this is very important. So babies who didn't survive, they had more Firmicutes and Acinetobacter than protobacteria. So this is just we have to study more even in this biases who makes you survive and who puts you at the risk. So this needs further study. These are our observation in our human tissue. So bacteria is just one part of microbiome in the intestinal gut. There are other non-bacterial microbiome. This American Journal of Perinatology, led by Dr. Javale. And we found that these bacteria are dependent on the virus, a lot of bacteriophage in the intestine to grow and to have healthy colonization. So there is and this field is also evolving, like your microbiome, fungal infections in the intestine, as well as virome. They are all independent with each other, your bacteria, virus, and fungus. So with probiotics, we are just working with the bacteria part of it. But it's much more vast, and we need to understand more about virome and the fungal microbiome. I'm not going too much into it, but just giving a little clue how they are independent, how they are work together to have a proper healthy microbiome in the gut. So there are a lot of genetic factors also involved with surgical neck. So in these tissues, we also subjected these tissues, looked at the immune response. What kind of immune genes are expressed or underexpressed in babies who survive or who does not survive, and who gets more necrosis of the bowel. So we did. So in this study, as you can see, these are the patients, number of patients taken for this analysis, and these genes expression on genes expression. As we can see that with necrosis, and there are a lot of like underexpressed is represented in the blue lines, and with the red there is more expression of these genes. And these genes belongs to basically they had differential gene expression with the genes related to host defense, cell signaling, development, and apoptosis. Probably all these factors comes together, and or your placental exposures, your postnatal exposures affect these genes, host genes, and they cause under and overexpression leads to necrosis and putting the baby at risk of mortality. So understanding these pathways is very important, and as the field is growing, we are doing more and more genetic with the whole genome sequencing. Probably it will help us to have a more genetic approach down the line, which it's an upcoming field. We've also looked at in this is our own study where we looked at the epigenetic changes. Like sometimes these genes are modified by DNA methylation. DNA methylation is the most common postnatally they are exposed to all these things, antibiotics, oxygen, or any exposures, ventilator or blood transfusion. They affect all the DNA methylation of these genes, and which which can lead to under or overexpression of certain genes. As you can see in this poster, which was presented at PAS, although we have published the paper also. As you can see, there's so many gene network analysis was done, and we found that RAP1 signaling pathway was overexpressed. As you can see, like we had 20-25% cases were uh, big number of sites, like a lot of sites were methylated. Almost 46 sites were 25 to 25% methylated. And these are different signaling pathways, as you can see, are DNA by modified by DNA methylation. So survivors and non-survivors have very different DNA methylation pattern. There are other factors. So this is very important to understand the epigenetics. Factors also play a role, and it helps us to identify certain pathways. And we recently published a report where we found that in baby with NEC, there is a lot of mitochondria, there is energy failure. You see, it's a lot of lactic acidosis, a lot of metabolic acidosis in baby with surgical neck. So there is a lot of dysfunction. All these LPS bacteria or microbiota dysbiosis affect a lot of mitochondrial function of the intestinal epithelial cells. So there's a mitochondrial dysfunction. So I'm right now looking at the mitochondrial epigenomics right now. Probably will present that to PAS. So there is a lot of which is central to this, causing which orchestrate a lot of necrosis, a lot of dysbiosis, and multi-organ affection. So there is a lot of there's a trial right now. There has been a lot of in last 20 years there was some question about transfusions. Blood transfusion leads to NEC. Then we found that it's the level of anemia which leads to surgical NEC or medical NEC, and then whether to feed these babies during NEC or during blood transfusion or not, whether this leads to NEC or not. So this was the question. So we try to, although a meta-analysis was done, we also analyzed all the available data. This was published, I think, this year or end of last year. And I'm thankful to Dr. Patole who helped us with this meta-analysis. And we took all the data in this study. We took all the randomized control trials where we clubbed together all the data where they took the low hematocrit cases versus group versus high hematocrit, high threshold. And we also took case control studies and the erythropoietin studies in this meta-analysis. And we found that different results in different groups. The RCT evaluating transfusion thresholds, we did not find any significant difference between low versus high hemoglobin group. But the RCTs evaluating the recombinant EPO versus placebo, they showed higher incidence of NEC in the low group as compared to hemoglobin. And if you look at the case control studies, we found there was association with lower hematocrit levels in NEC cases compared to controls, and we found a mean difference of 0.28 in this. So lower, probably, and when we combined all the data, we found that probably the lower hemoglobin put the gut at the risk of injury, intestinal injury, probably because gut is hypoxic and with the feed going on. So probably there is a happy point around 27, 28, where the gut perfusion is maintained with adequate feeding. So that's it's still, we need more trials to understand this question better. Regarding the feeding, there is a wheat trial going on right now in Australia. I talked to Dr. Boli Shetty, and probably we'll be hearing those results soon. And whole world is waiting for those results, whether to feed these babies or not. Although initial trials shows baby can be fed during transfusion. If you look at a lot of these babies with surgical NEC have positive blood culture. Whether it affects outcomes or not. So if you look at the NEC blood culture sent at the time of NEC onset, if we saw that these babies, 24% of these babies grow gram-positive bacteria. And you look at, if you 24% of these babies have positive blood culture. Out of that, 15% are gram-positive bacteria, 10% gram-negative, and Candida was seen in 2.8%. This is important because if you're looking at, we found a baby with gram-negative sepsis, they had higher portal venous gas. And they need more platelet transfusion before NEC onset, and they had high CRP level as compared to babies who got positive infection. This is important because if you're looking at portal venous gas on the X-ray, then you can say probably I'm dealing with more with the gram-negative sepsis in this baby. This baby would be more sick. We will need more blood platelet transfusions. And they also had very low level of lymphocyte counts. So we are learning that there is a very altered monocyte macrophage system in these babies. We are writing a report regarding that. That it can be act as a biomarker as well as a therapeutic potential. Uh, So going to the next, this is all about pathophysiology, little upcoming pathophysiology. So next section is, I'm going to talk a little bit about what happens to the neck, which happens in first 10 days of life versus which happens later on, and are the outcomes different based on the sex, and how it differs with intervention. So if you look at this, in this study, we had taken 151 cases. Out of that, if you look at the histopathology, uh, if a baby who get a pneumoperitoneum in first week of life, we default label this baby as SIP. Labeling the baby with SIP, we studied that label with the histopathology, and we found that when you label a baby with SIP, just based on pneumoperitoneum first week of life, there is only 15% chance that you will be right. 85% of times, these babies behave like neck. So it's very important to see the clinical course of the baby, whether it was just a benign perforation, whether baby needed stricture, more surgeries, or if baby losing more than 3 to 5 centimeter of bowel length, it's more sort of a neck case than SIP. And secondly, if you're labeling this baby as neck, it's 75% of times you will be right, this baby has neck, and only 25% of these babies behave like a SIP. But uh, so this is very important to understand the pathophysiology and the clinical course to label these cases right, because a lot of data which has been published so far, SIP cases has been labeled based on pneumoperitoneum, and our diagnosis may be wrong. So the published data without histopathology, it gives a very heterogeneous results. That's why we have not been able to understand the outcomes of this disease properly, because there is a faulty diagnosis of these SIP cases and the neck cases. And the same thing where we had a division of these cases based on the neck onset. If you look at this neck onset, almost 35% of this disease present in first 10 days of life. And 37% of these cases present in between 10 to 20 days of life, and more than classical neck, which we say 3 to 4 weeks after birth, presents just in 25% of cases. And the disease is very different, which presents at different age. As you see that babies who presents early, less than 10 days of life, they had higher gestational age, they had higher birth weight, and infants had more pneumoperitoneum, and they had lower CRP after onset, and they had less AKI by creatinine present as compared to babies who get neck onset after 20 days. So babies who get neck onset early, so they have lower CRP because your immune system is not mature. The inflammatory response is not that severe. As you grow, babies growing like 28, 29 weeks have more inflammatory response. Your kidneys are at more risk of SIRS, like your inflammatory response after any of these. So kidneys are affected by inflammatory injury, by hypotension. You see more hemorrhagic lesions in the neck tissue. As you age more, there are more response, and you see more severe outcomes. And this is again like which I just told you. X-axis shows the level of inflammation, grade of inflammation, 0 to 4, and necrosis also 0 to 4. And this is the age of neck onset. As you can see, these are number of days when the neck present. The probability of inflammation increases. As you can see that in neck happening in first 10 days of life, mounts less inflammation, less necrosis as compared to, and more you see more level of grade 4 necrosis and inflammation as you mature more. So that's why you see you lose more bowel, they're more severe as compared to neck, which is happening in the earlier part of this, is more gestational age based and maturation of the immune system, uh, and all those factors. Sex specific outcomes. We asked this question whether male and female infants behave differently and what are the outcomes of surgical neck based on the sex. And we found that female infants with neck had lower median gestational age, lower birth weight, they had higher vascular malperfusion on intestinal pathology. They lost less bowel as compared to males. They needed less dopamine, and they had lower hematocrit levels before neck as compared to males. They had higher frequency of surgical morbidities as compared to males, but they survived more as compared to males. And they saw a lot of more wound adhesions and wound infection compared to male group. So they work very differently, both males and females, surgical neck outcomes. This is again a odds plot showing which are factors positive, and blue, which is like you see a lot of blue lines exhibit most likely associated. You see a lot of morbidities, wound infection, you see less dopamine support, and less bowel dissection. So I know Australia is a land of randomized controlled trials, and there has been 3 trials understanding the impact of intervention in this area. The last trial, understanding what were the outcomes in terms of use of penroseline as initial therapy versus laparotomy. And the last trial, which was done Blakely, published by Blakely in 2022, they include the baby with less than 1 kilo and first 2 months of life, and they found that there was no significant difference in the death or the neuro NDI, like neurodevelopmental impairment at two years of age. And however, these trials have its own problems. They don't make a neonatologist wiser, because we published a report. We looked at these trials because these trials does not tell me. Because these trials did not include clinical and hemodynamic status before intervention. They did not include the time in hours before clinical onset. What was the timing of the surgery? When did they operate these babies? They did not confirm their cases with histopathology, as we saw how it can fool us without not including the right diagnosis. And they did not tell us how these interventions affect the systemic morbidity like AKI, white matter injury, ROP, and BPD. So let's go to second half of the talk, which is AKI, infants with surgical neck, risk factors and outcomes. For this study, we took a cohort of 202 babies, and we found that the AKI was seen in almost 46% of these babies at any kind of AKI. So in this group, we classified our AKI by KDIGO classification, which takes into account by AKI by creatinine and the urine output. And we found that babies who had AKI by creatinine, almost stage 1 was seen in 17% of cases, and 17% of these cases had almost stage 2, stage 3. And urine out, if you look at the AKI by urine output, we saw that the stage 3 was seen in 7.4% of cases, and 15% had AKI by urine output. So what we did, we compared the AKI by urine output criteria and the creatinine criteria together with stage 0 and stage 1, and we looked at the outcomes. And we found that if you look, I'll show the outcomes in the next slide, but we also looked at based on gestational age also, AKI. And we found that in the same cohort, babies who were less than 27 weeks of gestational age, they had double the rate of AKI following NEC, which is 46% versus 20%. And they found that in infants with gestation more than 27 weeks, male sex or nephrotoxic medication exposure were associated with severe exposure based on in the babies who were more than 27 weeks. So if you look at these babies with severe AKI, we had 200 cases, and we found that we saw severe AKI in 66 cases compared to 136 cases. And we found that these babies who had severe AKI, they had lower gestational age of 26 weeks versus 29 weeks. They had lower birth weight, like around 900 versus 1.3 kilo. They had more exposure to the PIH, vascular injuries, probably it affects and they're more exposed to steroids also. I know this area needs to be investigated, whether exposure to steroids antenatally affect the kidneys or not. So this is very important. We found they were more exposed to antenatal steroids as compared to infants without AKI following NEC. And we found that if you look at a lot of these babies who had severe NEC, they had more surgical NEC, stage 3 NEC, put the baby at risk. They had more pneumoperitoneum. They had more fulminant. They had more ostomies. They had all the losses from the intestines, putting the baby at risk of, and the cholestasis, more sepsis is seen in cholestasis cases. And if you look at what are the hemodynamic factors, these babies who had severe AKI, they needed dopamine use. They were hypotensive. They were needing a lot. Their sodium level was less. They were very hyponatremic. The kidney, they were retaining a lot of fluid. Third spacing was seen. They had blood culture positive sepsis, which affects the kidney injury as well as inflammatory response. All these factors comes together. They lead to severe injury. We saw more we saw like a lot of less use of gentamicin. This was in severe neck, but this is very opposite because we change antibiotics to other zoosin in these groups, and this is severe practice in late onset neck where we use less gentamicin in these babies. Although we did not see any difference in terms of antibiotic duration in our cohort. What happens to the physiology, renal physiology in this baby with a surgical neck? If you look at this is the first graph shows the serum creatinine patterns. This is day zero tells you about on x-axis is the onset of surgical neck. As you can see that baby with serum creatinine have rise in the serum creatinine after 24 hours and which stays elevated for 14 days. It takes long time for the renal function to come back. Probably there is a lot of nephron loss and a function is affected. And if you look at urine output also goes down in first 24 hours, but urine output recovers pretty good after 24 to 48 hours in babies with severe AKI as compared to mild AKI. And as similar patterns we saw on the babies based on gestational age differences also. And this is a serum sodium concentration. As you can see, it goes down, then it recovers pretty good in 2-3 days. The hyponatremia is better. And on the multi-regression also, we found that in the adjusted model, the surgical neck, crowd bone status, positive blood cultures, antenatal steroids, they were associated with severe neck following severe AKI following neck. It affects the if a baby gets if baby with surgical neck gets severe AKI, they had longer length of stay, almost a difference of 40 days, which is a long in terms of dollars. And death-wise also we saw when you take the cases with no AKI versus all cases of AKI, we saw increased mortality trend in babies, which was almost 10% difference. Although when we took this group, it was not statistically significant, but we saw the trend towards higher mortality in severe AKI group. We also looked at the how severe AKI affects the post-operative outcomes and the brain injury in this group. And we found that babies who get severe neck, probably the gut is very inflamed. They are not able to, gut is not able to recover fast. So they had longer post-operative ileus days. As you can see, 14 days versus 9 days. They had longer day of starting feed. So it makes us wiser clinician. If you're dealing with a severe AKI, you can tell family that probably we will not be able to start feeds early. Probably the outcomes post-operative recovery will be longer. So use AKI as a marker for outcomes. And if you look at the severe, so what we did, we looked at the impact of AKI following neck on the white matter injury, which was detected on the brain MRI. We found that on the ordinal scale, as your level of AKI increases from stage 1 to stage 4, you are seeing higher odds of white matter injury, 6.2 odds ratio, which is, but not if you do a binary scale, it was not significant. But on the ordinal scale, we found a difference. So you're putting the babies at high risk for white matter injury. And if you're needing support, inotropic support after neck, following neck, so the more risk of white matter injury also you look at this, very important. Use of inotropes and so basically, in a summary, we can say that association of AKI and white matter injury on the ordinal scale, probably AKI in units with surgical neck, it may exacerbate brain injury by acting as catalyst or a modifier of neuroinflammation. We need more renal protective strategies around neck, probably managing hypotension better, less use of nephrotoxic drug, better fluid management in these babies. So this is another slide, same slide regarding outcomes. It affects post-operative ileus days, length of stay, and white matter injury. And why this electrolyte imbalance seen in the neck? We did a mouse study in an animal model. We found that probably it affects the neck affects, and all the sepsis affects your tight junction proteins, which controls the water and the electrolyte balance in the nephron. So key points probably in a summary: infants with neck who transferred came from outside hospital to the referral center required surgical neck, positive blood culture at higher odds of severe AKI, stage 2, stage 3. By assessment of urine output is very important with neck. Without it, if you're just labeling your neck AKI just by serum creatinine criteria, you may lose 11% of those cases we see where AKI in the analysis. Very important to understand urine output criteria also. It affects recovery, hospitalization, and white matter injury. So we need strategies in the pre, peri, and post operative period to improve the morbidity and mortality in this group. So just last half of the thing, we have 15 minutes. I will just touch base on the gut-brain axis. As we know, the surgical neck is associated with the poor neurodevelopmental outcomes. There is a gut-brain axis. There's a lot of understanding going on. There's a meta-analysis by Matai et al. Published in 2020, and they found that 40% of these babies have poor neurodevelopmental impairment. 18% of these cases have cerebral palsy. PVL was more seen in babies with neck as compared to other groups like normal PVLs. So how the gut lung are correlated? This is a cartoon showing this is the gut. As you can, it's exposed to so many pathophysiological factors which we just talked about. It leads to activation of TLR4 or cytokines release after neck. It all affects the maturation of oligodendrocyte progenitor cells or the myelin, basic myelin. So there's a demyelination of the basal ganglia and other parts of the brain, and it activates it deactivates the neuroproductive genes, and it stimulates the neuroinflammatory genes. All this comes together and lead to brain injury, neck-associated brain injury. So what is just a little bit same thing? Probably, baby, as we know, baby with surgical neck, they have higher inflammatory markers in the blood as they have severe wide matter abnormality, and they have adverse outcomes at 2 years of age. Animal studies have also found it causes neural injury by microglial activation, inflammatory pathways, and the brain barrier disruption. So we did a clinical study in our unit where we a lot of published data in the past was based on the ultrasounds or just the neurodevelopmental outcomes. Here in this study, we looked at the brain injury with surgical neck on the brain MRI, which was done at a term equivalent age, and we looked at all the possible. For this study, we had total 121 cases, and babies who survived for MRI were 69 cases. And we out of these 69 cases, we looked at all the factors the baby is exposed to, like prenatal factors like choreo, infant demographic factors, neck factors, age of neck onset, timing, surgery timing, post-operative course, and the RBC transfusions and the sepsis, whether steroid exposures, length of stay, and sepsis variables. Because all these factors comes together, whether it affects the brain injury or not, and we did different kind of modeling to understand this question. So in this group, we had 69 cases. We found that these both the groups were pretty similar in terms of gestational age, 25 weeks versus 27 weeks. And if you look at this, we saw mild wide matter injury. We used the Woodworth classification on MRI for classified brain injury. We saw that only 24% of these cases had mild wide matter injury, and 18% of these cases had moderate injury, and 9% of these get severe brain injury. And we looked at different parameters on MRI: loss of periventricular volume, dilatation, corpus callosum, thinning of and the wide matter signal abnormality and cystic abnormality. And this is the score, and we classified probably 25% had almost mild, and the rest of them had moderate to severe injury. And this is the MRI. As you can see in the grade 3, there is a more cyst. You can see more dilatation of the ventricles. And gray matter injury was not statistically significant in 2 groups, and we found it was seen in 10% of cases. And we included loss of subarachnoid space and the extent of gray matter signality. And if you look at the histopathology, what happened to the histopathology in white matter injury, and we found that these babies had higher mean hemorrhagic scores as compared to babies who got mild white matter injury. Probably there's a lot of blood loss in the intestine, a lot of hemorrhage. So that's why it's important to understand the neck histopathology. More lesions, hemorrhagic lesions, putting the baby at risk of white matter injury. We saw the less necrosis score in severe white matter brain injury, which is grade 3, grade 4 versus normal to mild injury. We ran a different model, clinical and the histopathological model, and we found that babies who got, this is a clinical and histopathological model, as you can see in this column. We found that babies who got severe white matter injury, they were exposed to red cell transfusion before neck. They had even the age of neck onset was earlier. I'll show you that. If you look at this, this last columns are more severe injury, and we found that red cell transfusion, age of neck onset, and the hemorrhagic lesions. Basically, if you see more hemorrhagic lesions, they are putting the baby at high risk of severe injury. And this is a probability white matter injury based on the age of neck onset. If your age of neck onset is early, as you can see that in first 30 days, there are high probability of white matter injury as compared to if your age of neck onset is later on. But if you post-operative years also makes you wiser. If you're not able to start feeding in the babies, like in first 10, 12 days after surgery or 2 weeks, or if you are starting feeds later on, probably the gut is very sick because of AKI, other problems, sepsis. So there are more chances of white matter injury. So post-operative years days, starting feeds also makes us wiser whether this baby is at high risk of white matter injury or not. They should be under intense follow-up in these cases. And we saw the same patterns: poor motor outcomes and cognitive scores at 2 years of age by Bailey's. And we found almost 10% of these cases have auditory losses. And the ROP was seen in almost 50% of these cases in surgical neck, and 44% of these babies has long-term eye complication like myopia, need for glasses, strabismus, nystagmus. So those things were also seen in our cohort. So this is summary, and basically we saw in this our cohort we saw white matter injury in 52% of cases, gray matter injury in 10%, and cerebellar injury in 30%, which I'll just show. There less necrosis, more hemorrhage, and infants with white matter injury more likely to severe post-operative course, AKI, and longer hospitalization. We need to have neuroprotective strategies following neck to improve the neurodevelopmental outcomes. Just a quick take on the cerebellar injury. In the same cohort, we looked at the cerebellar injury, and we defined cerebellar injury by looking at the cerebellar hemorrhage or by looking at the loss of cerebral volume, and we defined hemorrhage by looking at cirrhosis and or parenchymal hemorrhage. As you can see in the MRI, these white shadows. These are the hemorrhage, and you can see the loss of volume also. Like these are the so these are the hemorrhagic areas and loss of volume. As you can see, loss of volume, white areas more, CSF space. And we found that almost 32% of these babies cerebellar injury. And the risk factors which were associated with cerebellar injury, because it's a very highly growing organ in these babies. They had PIH less often, they had less pneumatosis, they had more hemorrhagic lesions again, affecting the perfusion of the posterior brain. They had more PDA. PDA also affecting the perfusion. There is a vertebral steal phenomena. The blood is not reaching to the cerebellum. They receive more blood transfusion because there is hypotension going on. They have more blood culture positive sepsis, mainly gram positive. It's very important. Gram positive sepsis is not benign. We saw a trend. We saw it probably gram positive LPS affects a lot of myelination, volume loss in the cerebellar regions. They had more cholestasis also. Babies who did not get cerebellar injury, and we saw on the multi-regression they had more positive blood culture sepsis, more PDA, and even the more hemorrhagic lesions, which were significant out of these factors. And we also looked at the growth, how the growth affects following neck until you are able to reconnect their gut. And we found that these babies who this is a work in progress paper. Here we found that babies who are at high risk of white matter injuries, they had moderate to severe white matter abnormality. They had lower length. They had lower head circumference before reanastomosis. So it needs a different kind of feeding protocol following neck in baby surgical neck. We know there is a standardized feeding protocol, but their needs are very high. We have seen that this is one of the factors which can be modified. The growth following neck, first 8 to 10 weeks following neck is very important. And we saw a similar pattern in the cerebellar injury also. We saw after resection that these babies had lower weights. Even the head circumference was also lower. So very important to improve the calories and the proteins in these babies. Just switching gears about neck versus SIP. What happens in the brain injury outcomes in neck versus eyes? So there is a lot of inconsistency between the outcomes because they lack proper diagnostic criteria. So in our study, we used the histopathological criteria for neck and SIP cases, and we found that babies there was no difference in the white matter injury. Probably and there was no difference in the white matter injury neck and SIP. Probably tells that when you classify these cases by histopathology, there was no difference in the outcome. Probably they lie on the same spectrum of the disease. And this is function of gestational age. These babies are also exposed to a lot of analgesics and sedatives. And here we looked at their outcomes. What happens to with their exposed following NEC, and there are a lot of sedation like fentanyl, midazolam, and there are a lot of exposure, how it affects a white matter injury. And we found that these babies, although there was no difference in the exposure to these sedatives in two groups, although these babies were exposed to more surgical procedures, and they had longer duration of hypotension following surgeries. So all these medications leads to hypotension, and the neck itself also leads to hypotension. So we have to make sure we are managing hypotension pretty well in the OR before neck and after neck, because a lot of factors coming together, putting the brain at risk of brain injury. So this is our, as I just said, they need even more hydrocortisone following neck. They had more hypotension, they had more surgeries. This is an area where we can have an improvement. And all these data points is because your blood regulation, the autonomic regulation of blood flow in the brain is very poor. So that's why these factors also leads to affects the periventricular. And the long-term outcomes of these cases, if you look at white brain injury outcome, neurodevelopmental outcomes, there were no significant differences. Probably a lot of therapies, a lot of high-risk clinics at school age treatment and management leads to good outcomes at 10 to 15 years of age. And what is the impact of this? Last just a couple of more minutes. In this study, we looked at also the timing of surgery, how it impacts outcome in these babies. So we looked at how if you're operating a baby within 48 hours versus 96 hours or more than 7 days, and we found that there was no significant difference on the white matter injury. Although we found high risk for like moderate injury was in 30% of cases. Probably these babies are very sick who were getting operated early, but it was not statistically significant. It needs larger cohort to understand this question better. But and regarding the impact of AKI, impact of timing of surgery on neck, we found the infant receiving laparotomy after 48 hours, they had higher AKI because there is a dead bowel. There is a lot of hypotension going on, hemorrhage going on. It puts the kidneys at high risk for injury, severe injury, 75% versus 47%. Those receiving surgeries after compared to receiving surgeries early. So you are by operating early, you have to tell your surgical friends, operate early. We can't sit on a baby because putting the risk of higher neck associated morbidities. So we also looked at in the binary fashion what happens to the babies with mortality, white matter injury, and intestinal failure. And we found that there was no significant difference, although the odds of death were 1.5 times higher for subjects with more than 48 hours of surgery. So longer you take, although this was just a trend, but we need larger sample size. But if you are operating more than 48 hours, babies at more risk of death. Operating early, you're giving them better chance for survival. Even the odds of intestinal failure were higher if you are operating more than 96 hours because your process of inflammation is still going on until you take the bowel out. So you can't improve the outcomes. So on the continuous, this was a binary fashion. On the continuous modeling, we found that we assessed on the x-axis after how many hours you are operating on the babies and the probability of death. As we can see that as you are taking more time to operate after 48 hours, the probability of death increases. Although it was not significant, it's a complex algorithm. So that's important. Your probability is increasing of death as you are taking longer and longer. So as I just said, we need prospective study to understand the continuous relationship between time of surgery and outcomes. And so what are the future directions we need? We need prospective multi-center studies to evaluate renal and neuroprotective strategies to prevent multi-organ injury in preterm surgical neck. We need active management of growth, hypotension, AKI, sepsis and control inflammatory surge. I'm looking at the impact of steroids in this in a cell culture model right now, and we need serial neuroimaging probably after neck every 1 to 2 weeks to understand what part of the brain is affected. I would like to thank a lot of people, my departments at UMC and Wake Forest University, my family, especially thanks to Dr. Inder and Dr. Ashkenazi for AKI work and Dr. Maheshwari, which gives me very, very good insights to understand this problem and all the patient families. And I'm happy to take more questions. Thank you so much.
Oh, Parvesh, that was such an amazing, amazing talk. Thank you so much for guiding us through this exciting bit of research and pathophysiology. While the people are typing in the chats or putting their hands up, I would like to start with a question, if that's okay. So, um, as you beautifully explained, a neck is not only a surgical problem; it's a multi-system problem. And I was wondering if you would, if you have any insight in if we need to assess the systemic inflammation better. Are there any clinical or lab parameters that we can measure? And the same for common pathophysiological pathways like endothelial dysfunction, for example. Is that something that you have studied or that you would recommend studying further, or from a clinical perspective, what can we do with this information?
So very good question, Dr. Anka. So diagnostic, that's why we don't have a report standard diagnostic biomarker. It's such a very complex disease, because if you look at the pathophysiology, some babies get necrosis, some babies get inflammation, some babies get inflammation. So there is no standardized biomarker right now. First of all, you can look at the hematological recovery clinically, whether platelets are improving following NEC or not. If your platelets have stabilized, that means your inflammatory cascade has stabilized. Some people look at the CRPs coming down, which are two most clinically important biomarkers people look at, whether your blood culture is negative or not. So some people look at the calprotectin epigenomic biomarkers like microRNA and all those non-coding RNA. But these are the still there is no standardized because it's such a complex disease. We don't have definitive biomarkers to diagnose this condition. It is still based on the clinical factors. And I just published a report saying the paradigm shifting. The neck is just an end diagnosis. There are many physiologies comes together, leads to diagnosis of, it's a diagnosis. It's not it's a pathophysiological endpoint of many problems. So we have to understand these are the intestinal clusters. Based on that, we have to identify different biomarkers and assess those factors. It's a work in progress. And so right now we don't have answer which we should target for diagnosing neck.
Okay, thank you so much. I think that also covers Kurt's question on the host response and inflammation. There are other questions in the chat. So what about the connection trial by Professor Joseph Noy, who showed lower mortality in the probiotic group with Lactobacillus reuteri compared to placebo? What's the current situation in the USA based on those results?
So regarding the connection trial, we were one of the site. But if you look at when you subgroup that trial, like less than 14 days of life, the need of surgical neck was less in the probiotic, but overall there was no difference in mortality. They found that probably they were able to reach feeds early in the connection trial. Still, after this trial, probiotics are not FDA approved in the USA. Some people use it, some units use it, but it's not a standard of care as it is in Europe and Australia, Canada. People use more widely, but there's a data supporting it in neck cases. But in the US, it's a you need approval before you put the baby on probiotics.
Yeah, so work in progress there. A question regarding current practice. So in your unit, there's a question regarding perforated neck or SIP. If your unit practices peritoneal drainage or laparotomy.
So in our unit, basically surgeons try to put the baby on the Penrose drain. So that's their first line. But as a neonatologist in our unit, I always ask them if a baby is not improving within 12 to 24 hours, needing a lot of inotrope, needing a lot of blood transfusion, kidneys are not functioning, your lactic acidosis is there. You have to push for early surgery. As I showed in the data also, your probability of death and outcomes changes as you wait longer. So you don't have to wait for surgical friends to tell you when to operate. As a neonatologist, as a nephrologist, you have to operate this baby early. So that's the paradigm shifting. Right now, as a neonatologist, have to advocate for surgeries for these babies. for better outcomes.
And a related question regarding the location of the surgery. So there are some newer studies that say that a location in an operation in the NICU would be better than moving them to theater. Did you compare the effect of location of the surgery in the operation theaters versus the NICU?
No, I didn't. We did not assess that part, but most of the surgeries in our NICU are done at the bedside. But it's a good question. But probably they take a very sick baby to the OR. But if they're able to operate and able to manage babies, they try to do at bedside also.
Yeah, I think that's also a very interesting bit of research to see. Is it only the sicker babies that you need to take to theater, or the opposite, to keep the sicker babies in the NICU and not having them move to theater? I think there's still lots to clarify there what's best for the baby. There's another question regarding AKI post-NEC and the need for renoprotective strategies. Did you include any data on NEC-induced AKI progressing to chronic kidney disease and the need for renal replacement therapy?
So a lot of these babies recovered pretty well after surgery. We did not see any babies needing peritoneal dialysis or any kind of some of the babies used the hypertension down the line, but we don't have any long-term follow-up data in baby with surgical NEC and the AKI. So that's why baby with severe AKI, they need to be followed up what happens to their kidney health in terms of young onset hypertension. But none of them needed any renal replacement therapy. But it impacts your immediate post-operative outcomes and the white matter injury. It can make you clinically sound and wiser to understand the outcomes.
Thank you for that. You're preaching to the choir here, but I think it's very important that in these children with AKI, and particularly with NEC and AKI, that we make sure that we follow them up and prevent chronic kidney disease in childhood, but also in adolescence and adulthood, to make sure that we, I think as pediatricians, neonatologists, we have an obligation to promote healthy aging and not have these former preterms on dialysis when they're 50, just because the hypertension was not detected. Sorry, that was a shameless plug of the nephrologist. There's another question regarding your cutoff for PCV to transfuse red cells for growing extreme premature babies on 20% FiO2 with bubble CPAP.
So
sorry, I need to read this question again. So what is your cutoff for PCV to transfuse for well-growing preemie babies without any oxygen requirement on bubble CPAP to minimize the risk of NEC when the preemie is still in the age to get NEC?
So in my, the practice is varied between different neonatologists in the unit, but my personal practice is if a baby hematocrit is less than 27 or 28, I try to see a baby if he's getting any apneas, bradycardias, whether it's affecting the growth or not, whether it's getting other problems. So I try to transfuse this baby. Sometimes we use debrapoitin or the erythropoietin injections if there is a high retic cell count to avoid transfusion. But if you are getting lower and lower, you have to see the overall picture of the baby, whether high iron intake or high, whether debrapoitin can help you, or if you're seeing a trend in increase in your hematocrit, every serial hematocrit. So you have to make a decision clinically whether to transfuse or not. But for me, below 27, 28, I get very, very cautious and assess the baby clinically every day, what we need to do.
Yeah. Thank you. I agree with you, and also I really liked your focus on hypotension. I think we need to really use our clinical judgment when we need to treat hypotension gently or aggressively to prevent both NEC and AKI and brain perfusion, as you beautifully showed. There's another question about the diagnosis of NEC, and should we use ultrasound instead of the outdated Bell's classification?
Yeah, the Bell is broken. We just published a paper like NEC paradigm shift. and even a paper we have published on ultrasound, we found that there's a lot of implementation issues. You need first of all, the radiologists are not comfortable in assessing the bowel of preterm babies, number one. You need a lot of like bedside training of the neonatologist registrars to understand the bowel and the what is, and you don't need one-time ultrasound, you need serial ultrasounds. Like you have to see the baby, how the gut is perfusion is changing every like 12 hours. See, so there is a role of definitely it can help us. Complex ascites, loss like loss of peristalsis, all these factors, complex signals. But you need serial ultrasound. If you have a better protocol, standardized protocol training, definitely go for it. It can help you even to start feeds early also after NEC. If there's a return of the bowel peristalsis and your signs going away, portal venous gas going away. So it has definitely a role, but you have to standardize the care in your center.
And there's a linked question about the association of intestinal vascular malperfusion and NEC. Is that something that you further explored?
Yes. So I think we saw in the placental lesions, and we usually don't start feeding that aggressively in these babies. So what we do, we stop antibiotics early. That's my personal practice. And we try to slow feed 10 ml, 20 ml per kg per day very slowly, because your gut is very, very hypoxic and a little retarded in terms of growth. So you have to expose these babies a little slow with the feeds and be watchful. They're definitely at risk of NEC. And so you have to see clinically how baby is doing with use more mom's milk as compared to formula or donor milk we use to prevent NEC.
And then the last question, if you use intravenous pentoxifylline or oral antibiotics for babies with surgical NEC, and if you have a biobank for all surgical cases in your institute.
Yes. So the thing is, we don't use pentoxifylline. There has been some data which has been used for improving the gut perfusion and all those things, but we don't use pentoxifylline, although there has been some published trials. Secondly, regarding a biobank, there is a repository in my neighboring institute at UNC Chapel Hill. They have 50 sites where they collect the samples, but you need to you can use that sample. There are certain conditions. You have to there is a biobank, but we usually extract out our tissues from in the pathology lab if I need any samples, but we are routinely not collecting all the biosamples. But there are some biobanks in USA, definitely, led by Dr. Misty Good.
Parvesh, I would like to thank you again for this excellent talk and for the great discussion and questions from everyone in the chat, and for everybody for attending this great lecture. Parvesh, good night, and for the rest of the people all over the world, enjoy your lunch or your dinner or
Thank you, Anka. Thank you, Dr. Ovi, and everyone in Australia. I really had fun discussing about NEC.
I hope you all have a great day.
Thank you so much.
Thank you, both of you. Thank you, both of you. And next week, we have Liz Fogler talking about supraglottic airways. So have a great evening, Parvesh. Thank you so much, Anki. And see you all next time.
Thank you. Thank you, Dr.
Bye.
Bye. Bye. See you.